I would like to invite Dr. Karthik Madhesh from Chennai to the stage. He will speak on hypoglossal nerve stimulation, a game changer in OSA management.
Shankar for planning the sequence of presentation properly. I was this scared when Dr. Anand started with STAR and adherent trial. What am I going to speak if he's going to start on that slide? So good afternoon, everybody. The title says game changer, but let me be very clear. From the first sentence, this is not a device advertisement. This is a discussion about how neuromodulation is forcing sleep surgery to grow up from removing tissues to recruiting physiology. For nearly 3 decades, we treated obstructive sleep apnea like a plumbing problem. But the times have passed by. Now, presently, we are looking at, let's say, next 13 to 14 minutes. It's not about implant versus CPAP, nor device versus surgery. It will be a discussion on how precision sleep surgery, choosing the right patient, right phenotype, and the right mechanism means everything. So full disclosures, since we are talking about hypoglossal nerve stimulation and it involves a company and also I'm making it clear that no device and brand names are referenced, only where required by the cited evidence advance. And this talk is not sponsored, it's off-label investigation, evolving evidence points explicitly flagged as such where they may appear. So coming straight into the topic, I'm going to make a strong argument for hypoglossal nerve stimulation, but I'm not going to sell it as some kind of a miracle drug in the late night television advertisements. Hypoglossal nerve stimulation is not an alternative for CPAP, or it's not CPAP 2.0. It is an evidence-based option for carefully selected PAP intolerant or PAP non-adherent OSA patients where the airway phenotype is recruitable and the patient can engage with long-term device care. There is a strong objective and subjective improvement in selected cohorts. Durability is shown to be in 5 years follow-ups also, we have seen it. And then there is a real-world registry confirmation of the same. But the boundary between the cardiovascular outcome benefit remains unproven in multiple sham control data. So the person doing it often does not realize how disturbing it is to everyone else. I'm talking about snoring. So that's how a procedure or a surgery is. So why does this therapy matter now? Because the clinical gap in OSA is not simply efficacy, it is also its effectiveness. So OSA is not a boutique disease. It is a great global public health problem, but basically hiding in bedrooms. Based on evidences, it is estimated that 936 million adults aged between 30 to 69 years with OSA worldwide, with about 425 million having moderate to severe disease. PAP machines remain the first line of treatment when tolerated. Let us not be fashionable and the bashing up CPAP, saying CPAP doesn't really work for everybody. It works. The problem is that the patients remain magnificently human. Masks leak, noses block, spouses complain. So claustrophobia, travel, all of these things can create a disruption in your CPAP therapy. That is why this number matters. Mean CPAP use around 5.8 hours at 12 months is in one systematic review is shown, but it's still not same as a universally accepted lifelong solution. So to understand that reserve, to understand how exactly hypoglossal nerve stimulation plays a role in those patients with CPAP intolerance or non-adherence, we have to stop worshipping AHI as if it explains everything. So this is an important pivot worth considering. AHI is the label, the endotype is the engine. 2 patients can have the same AHI of 35 and be completely having different biological problems. One has severe anatomical collapsibility while the other has poor pharyngeal dilator muscle responsiveness. Another might have a high loop gain and another wakes up too easily because of a low arousal threshold. Same number, different disease behavior. So hypoglossal nerve stimulation mainly acts on the muscle responsiveness on the airway patency axis. It does not directly reduce the loop gain. It does not directly reset arousal thresholds. It does not magically dissolve the obesity-related collapsibility. This is not, that is not a weakness, that is the point. The precise therapy should have a precise target. And that brings us to the obvious anatomical question, why the hypoglossal nerve? A brief concept of that was touched by Dr. Anand. The target is not the tongue at all. That is too crude to say that tongue is what we are attacking. The target is directionally useful tongue motion, not the tongue itself. Selective recruitment of airway opening muscles, mainly genioglossus protrusion, at the moment of inspiration is extremely critical. In sleep apnea, the tongue base can behave like a badly timed curtain. During inspiration, the negative pressure pulls the airway inward. If the pharyngeal dilator response is inadequate, the tongue base contributes to the retrolingual obstruction. Now, hypoglossal nerve stimulation is designed to wake up the dilator response before the airway loses the fight. The surgical principle is beautifully simple but technically very unforgiving. It should include protrusive fibers, avoid retrocessor dominance, produce predictable anterior tongue movement. If you stimulate wrong fiber population, you are in for a terrible disappointment. So this is probably the only ENT operation where the patient sleeps and we wake up the tongue. So now let us move from target selection to the actual system. So how the system works. Now, HGNS is not a nerve cuff, not just a nerve cuff. It is a timed loop. A sensing lead detects the respiratory effort. The pulse generator interprets the breathing cycle. The stimulation lead activates the hypoglossal nerve. The tongue protrudes and stiffens the airway. Obstruction is reduced breath by breath, not by permanently holding the airway open. But the most important line is at the bottom, which I have mentioned. Implantation is the start of the therapy and it's not the end of it. There is implantation activation, acclimatization, titration post polysomnography, long-term optimization. Now the patient who has been implanted is not yet fully treated. We cannot wash our hands off. Programming converts the surgical potential into clinical outcome. So this is not those fixes like kitchen appliances or home appliances where you fit it and you forget it. That is why hypoglossal nerve stimulation changes surgical thinking. It is adjustable physiology, not just fixing the anatomy. Why it changes the surgical thinking? Now, UPPP, tongue-based surgery, skeletal surgeries, and multi-level approaches still remain very notably important, no doubt about it. But they belong to a different operating philosophy. Traditional surgery resects or repositions anatomy. Once healing is complete, the effect is essentially fixed. However, revision is often very, very invasive. Success depends heavily on whether the collapse phenotype matched the operative technique. Now, when it comes to hypoglossal nerve stimulation recruits the physiology, not the anatomy. It can be titrated. It records nightly usage. It can be combined with other phenotype-driven therapies. The surgeon is no longer only modifying the anatomy. The team is managing an adjustable neuromuscular therapy. So the message is, it's not less surgery, it's not about a replacement for surgery, it is a smarter surgery. The better question now is not what can I remove, it's about what mechanism am I treating. So it all begins with the patient selection. Now, when let's say selection criteria is considered the floor, then the phenotype selection is the ceiling. We have heard Dr. Saktesh, Dr. Sanu, all of us impressing upon us the importance of drug-induced sedated endoscopy. So the current US FDA labeling for Inspire UAS includes adults aged 22 years and above, moderate to severe OSA with AHI of 15 to 100, confirmed PAP failure or intolerance, and absence of complete concentric collapse at the soft palate. Now this BMA has expanded in the label up to 40, but please do not confuse the label expansion with equally expected response across all the BMI groups. Now that distinction really matters. A patient may be technically eligible, but still be a poor clinical bet. Higher BMI can increase the collapsibility and reduce the margin of response. And also most often than not, the criteria might change at the government policy level, but the payer or the insurance, the criteria might still be the same. So while you fit into the criteria, but for insurance company, you are still not eligible for the surgery. So the implant treats the obstruction. It does not treat insomnia, Netflix at 1 a.m. or marital or political conversation that you might end up having with your spouse. So it's important to identify the phenotype, and the DICE becomes the gatekeeper for the same. So let me explain how the DICE becomes the phenotype gatekeeper in a very short, small slide. So DICE is not a ritual anymore. It is not a decorative preoperative video. Two of the speakers have shown their algorithm of how they work on OSA. In our setup, we have made it a strong recommendation for the patients to undergo a level 1 polysomnography, followed by the next morning drug-induced sleep endoscopy. So it is a phenotype mapping video. If the collapse is at the velum anteroposterior, the HGNS may still work because palatal coupling can improve the tongue advancement. If there is a tongue-based AP collapse, that can be favorable because the therapy directly recruits the segment that is failing. But complete concentric collapse at the soft palate level is very different. It was excluded in the STAR trials and remains a contradiction for the Inspire UAS. Several lateral wall collapses is another danger zone where a combined therapy will be of an immense use. Epiglottic collapse is context dependent, which was dealt with very clearly by Dr. Anand, and it may improve or persist or require additional treatment. So DICE is like our Google Maps. Without it, we may drive confidently, but in a wrong direction. So now let's move on to the how strong is the evidence base for hypoglossal nerve stimulation. So before showing the numbers, we should calibrate the evidence ladder. The proof of concept studies told us that this could work. Next, the 5-year STAR follow-up addressed the durability. The ADHERE registry showed the real-world registry performance. Meta-analysis is pooled effectiveness and safety, and CardioSA 12 gave us sham-controlled cardiovascular outcome data. But here is the important scientific boundary. The mature evidence is strongest for unilateral, respiration synchronized inspiratory OAS in carefully selected PAP intolerant adults only. Other platforms, bilateral targeted proximal systems are exciting, but they are still lacking enough evidence or publications. So in sleep surgery, as in life, surname does not mean genetics. Moving on to the next slide, let's start with analyzing each of those evidences. Now this is considered one of the landmark trials, STAR trial, that moved hypoglossal nerve stimulation from an interesting idea to a serious therapy. The design matters. It was a prospective multi-center cohort of 126 implanted adults with PAP difficulty or intolerance. DICE excluded the retropalatal complete concentric collapse. The study also included a randomized therapy withdrawal phase in responders, which strengthened the causal inference. The median AHI fell from 29.3 to 9, 68% reduction that is. ODI fell in parallel from 25.4 to 7.4. Sleepiness improved and the ESS moved from 11 to 6 in most patients. Quality of life improved with FOSQ rising from 14.6 to 18.2. The power of STAR is that objective obstruction, oxygen desaturation, sleepiness, and the quality of life all moved in the right direction. But one thing which STAR lacked is it's not a baseline sham-controlled trial. It was a prospective cohort with randomized withdrawal among responders. So the next question is durability. At 5 years, the STAR follow-up showed 63% responder rate with sustained objective and patient-reported benefits in the follow-up cohort. This is important because the implantable therapy is a long-term commitment. A device that works for 1 year but fades by year 3 is enthusiasm, not strategy. The adverse event number belongs on the same, so the serious device-related events were reported in 6%, all related to lead or device adjustments. That is a favorable safety profile, one should say, but it does not say a zero morbidity. Hence, one can safely say durable benefit is real in selected patients only. It cannot be claimed that the universal lifetime cure is available with hypoglossal nerve stimulation. ADHERE registry moves HGNS from trial efficacy into clinical effectiveness. The registry matters because it reflects real clinics and real follow-up. Mean AHI fell from 35.8 to 14.2 at 12 months. ESS improved from 11.4 to 7.2. And objective device recorded usage averaged about 5.6 hours per night. Those usage data are clinically meaningful because HGNS, unlike most surgery, gives us nightly adherence information. The device does not simply ask whether the patient says they used it, it knows. Multivariable analysis also reinforces the same selection logic. Female sex and lower baseline BMI were associated with better response in registry data. So now let's move to who wins with this therapy. Responder selection is the core surgical skill. The implant does not fix the poor selection by the team. The device is not a magic wand. It is a very expensive mirror that shows sloppy phenotyping. Favorable signals include lower BMI, absence of complete concentric collapse, tongue-base AP collapse, that is recruitable, limited lateral wall collapse, low central burden, and disciplined follow-up through activation and titration. The clinical translation is simple. Do not begin with, is the AHI high enough? Begin with, can stimulation recruit the airway segment that is actually failing? That single change in question is the difference between a strategic implant and an expensive disappointment. So the best sleep surgeon of the future will not be the one who implants the most number of devices. It will be the one who says no to the wrong patient with confidence. So we all know when cases fail, the reasons are usually knowable. So why would hypoglossal nerve stimulation fail? Let's go through a quick review. We have talked about the criterion. So again, wrong phenotyping can be a major cause. It can fail because weight gain increases the collapsibility beyond what stimulation can overcome. It can also fail because of programming, amplitude, electrode configuration, respiratory timing or comfort, or because the patient never got acclimatized and does not use it, doesn't feel like using it. And at sometimes the AHI improves, but the patient still feels terrible because there can be associated other components like insomnia, hypersomnia, circulation, circadian disruption, or cardiometabolic fatigue. So failure is not a diagnosis, it is a workflow flaw, re-phenotype, reprogram, reiterate, and then consider probably a combination therapy. So that brings us to directly to what is this programming that we keep talking about. Programming is therapy. Implantation creates a potential, but it is not over there. Titration converts this potential into outcome. Now, activation defines the comfort range. Home acclimatization allows the patient to tolerate the stimulation during the real sleep. Titration polysomnography identifies the optimal settings. Long-term refinement responds to weight changes in the patient, positional effects, sleep stage effects, discomfort, and residual symptoms. The team must understand the amplitude, the threshold, the configuration, the tongue motion, phenotype, the respiratory timing, the patient comfort, awakenings, the tongue abrasions, the bed partner complaints, feedbacks. There is a whole gambit of things which a team has to be taking care once when the surgeon has implanted or after the surgeon has implanted. So if the surgeon thinks the job ends after closure, skin closure, then he or she will be in for a surprise. So now any implantable therapy needs a honest safety ledger. So safety must be seen with the same discipline as efficacy. Expected issues can be an incisional pain, stimulation discomfort, tongue soreness, or abrasions and temporary speech, or even swallowing sensations during the acclimatization process. Device-related concerns include lead or generator adjustments, infections, neuropraxia, device interaction, and MRI conditionality depending on the model. So in the STAR 5-year data, we saw the serious device-related events occurred in 6%, which is not zero, which is still low morbidity, but it is present. The patient is not just paying for an operation. We should all understand the patient is entering into a device care pathway which can extend for a reasonable amount of time. So what are the controversies surrounding this? Earlier we talked about FDA has expanded the BMI boundaries, but then the insurance companies have not expanded similarly. We talked about the complete concentric collapse, especially the cardiovascular outcomes. The sham-controlled cardiovascular study did not show significant short-term blood pressure or vascular benefit at all when it comes to the HGNS. So the AHA improvement does not yet equally prove or equate the cardiovascular risk reduction. Cost and access matter, we all know that. So where does hypoglossal nerve stimulation fit today? So this is not a ladder, it is a precision map. The CPAPs, the APAPs, weight loss strategy, mandibular advancement devices, HGNS, other combination therapy surgeries, all of these are tools around one patient. Now, the question is not which camp we belong to. The question is which mechanism the patient belongs to. So some patients need CPAP machine, some patients might still need an anatomical correction, and some of them might need a hypoglossal nerve stimulation. So if we get that right, HGNS is not a competitor to sleep surgery. It becomes one of the most elegant expressions of precision sleep surgery. So that brings us to the last and the central message. So the future of sleep surgery, we have discussed enough. So the take-home message is very, very simple. Hypoglossal nerve stimulation restores the physiology. It does not abolish the need for phenotyping. The strongest evidence is in carefully selected PAP-intolerant adults. Drug-induced sedated endoscopy and collapse phenotype are decisive selection tools. Durability is supported. Cardiovascular benefit remains unproven. The real game changer here is not replacement for surgery, but the dawn of a precision sleep surgery. Thank you.
Thank you, Doctor. And I request Dr. Anand Raju to join the stage to receive memento. I request the chairpersons to come to the stage.
So I've also not mentioned about Genio because it doesn't have a last leg. But it is there. It's quite exciting to know about Genio, but lack of evidences or developing evidences, so to say, has restricted me from going further. There are no 5-year outcome trial yet on this.
Thank you.
So actually this, after Sakti's conference, we have our Global Sleep Surgery Summit at Coimbatore, September 18, 19, 20. So it's a global sleep surgery event. Almost more than 30 to 40 international faculties are coming, as well as along with our national faculties. So it's a 3 days event. So 1 day live surgery, second day half a day live surgery, and 2 days lectures, and last day is a cadaver dissection. So sleep surgery lectures, and there will be exclusive dental sleep symposium is there, and pulmonary doctors also coming. Actually, there is a crossfire between CPAP and sleep surgery. So these are the international faculties are coming. Almost 2 or 3 people only are there giving a talk virtually. All others are coming in person. So from Italy, Mexico, from Bulgaria, so Russia, Oman, Peninsula, so from US, and these are national faculties, but national faculty is still more, almost more than 40 to 50 our international friends are coming. So, so it's a 3 days event at Coimbatore. It's a red is and blue. So 2 days live surgery, 1 day cadaver dissection exclusively. So after Sakti's conference, so those who really interest to visit, participate, please register. The registration is not very much actually. So this cadaver dissection is only 15,000 rupees, and the registration is only 8,000 rupees. It's ideal for so postgraduate as well as surgeons who wants to master in sleep surgery. So it's organized by Anandi India Hospital. It's a 3 days event. Thank you so much.
Thank you. Thank you, doctors. I request Dr. Anand Raju to honor the chairpersons.